Infective endocarditis is an infection of the endocardial surface of the heart, and although rare, has serious and life-threatening implications when it occurs in individuals who are at risk for developing this condition. A prerequisite for developing infective endocarditis is bacteremia, that is, the presence of bacteria in the bloodstream. Bacteria can enter the bloodstream in many ways, even with routine and daily activities such as flossing, toothbrushing, and chewing. Bacteremia can also occur during a medical and dental procedure in which bacteria which cause infective endocarditis may come in contact with the bloodstream. While it is hard to measure, most cases of infective endocarditis are not attributed to invasive dental procedures. As orthodontics is perceived to be the least invasive form of dentistry, it is often assumed that the risk of bacteremia is small. The American Heart Association, or AHA, provided guidelines in 2007 for the prevention of infective endocarditis in association with dental procedures based on the best available evidence. However, the guidelines for orthodontic treatment in infective endocarditis are minimal, and the available literature lacks high-quality evidence. The aim of this review was to provide an evidence-based update on the relationship between orthodontic procedures and infective endocarditis in children with cardiac conditions.
A comprehensive search of literature up to December 2018 was conducted. Because of the nature of this serious and life-threatening condition, studies which would be considered high quality, such as randomized control trials, were lacking. The available literature allowed for interpretation and reporting of a narrative synthesis. The AHA recommends antibiotic prophylaxis based exclusively on an increased lifetime risk of acquiring IE where prophylaxis is deemed reasonable for cardiac conditions associated with the highest risk of adverse outcome from IE. Before starting orthodontic therapy in patients with cardiac conditions considered at risk for IE, the patient's level of risk should be determined by referring to these guidelines. The recommended antibiotic regimen is a single dose of antibiotic, most commonly amoxicillin, given 30 to 60 minutes before the dental procedure. Antibiotics should be administered for all dental procedures that involve manipulation of gingival tissue or periapical region of teeth or perforation of the oral mucosa because transient bacteremia may result from these procedures. The only orthodontic procedure listed as requiring antibiotic prophylaxis is the placement of bands, where the increased risk is related to the subgingival location of the band margins. High-quality evidence is lacking on the relationship between orthodontic procedures and IE. From the review of literature, it was found that the reported prevalence following orthodontic procedures was generally lower than those reported after daily activities. Extractions are the dental procedure most likely to lead to bacteremia. For patients at risk for IE, extractions, when required, should be undertaken under antibiotic prophylaxis. However, it is best to try to avoid elective orthodontic extractions while considering orthodontic treatment plans. The placement of a separator and the placement of a band have been reported to lead to statistically significant increases in bacteremia. Procedures that have been reported to have possible clinical significance include the removal of a bonded palatal expander, removal of a Haas palatal expander, placement of a separator, and placement of a band. While orthodontists commonly prescribe antibiotics for the removal of bands, the available literature is inconclusive. The exposure of impacted teeth is a surgical procedure which requires antibiotic prophylaxis. However, after exposure, no further prophylaxis is required as the tooth movement is analogous to normal tooth eruption. Some authors recommend open surgical exposure because it has been debated whether traction after closed techniques increases infection risk due to a conduit along the gold chain. Due to the lack of high-quality evidence, orthodontists should consider all options, including premolar substitution, in patients with IE risk and deeply impacted canines. Bacteremia is influenced by the level of inflammation or infection at the site, and available evidence supports the notion that good oral hygiene and absence of dental disease decreases the frequency of bacteremia. Orthodontic therapy should not be initiated unless the patient's oral hygiene is impeccable, and oral hygiene and gingival health should be monitored throughout treatment.
Before starting orthodontic therapy in cardiac patients who are at risk for developing infective endocarditis, the child's level of risk for the condition should be determined by referring to the current AHA guidelines. Because of unresolved controversies surrounding orthodontic procedures other than banding, orthodontic treatment providers should consult the patient's cardiologist or primary physician to discuss the individual patient's risk of developing infective endocarditis. When possible, it is preferable to avoid elective procedures that may lead to bacteremia, for example, by using all bonded brackets and tubes instead of bands. In addition, tissue injury during orthodontic treatment should be prevented by avoiding sharp edges around appliance margins that can injure the tissues, securing archwires with elastomeric ties instead of wire ligatures, placing and removing archwires carefully to avoid mucosal injury, and avoiding fixed acrylic appliances which can cause impingement and inflammation of the mucosa. Clear aligner therapy can also be considered because it is a minimally invasive, removable orthodontic treatment modality. It is essential that the patient maintains very good oral hygiene during orthodontic treatment. For more information about this review, please read the article in the January 2020 issue of the AJODO. Thank you.